the Strength Beyond Struggle podcast and Ending the Silence program of the National Alliance for Mental Illness, NAMI, sponsored by Access. In every episode, we deal with difficult mental health topics, including suicide. So if you're struggling, remember, you can always get help by calling 988. Welcome to the Strength Beyond Struggle podcast. And today I had with me Melinda Claypool. She is we just talked about it, psychiatric nurse practitioner. So today we're going to talk about something called Tardive Dyskinesia. It is actually an issue with dopamine in the brain, and it's actually brought on by medications. So first off, Melinda, could you make our audience comfortable with what a nurse practitioner is? Because you're way beyond just a nurse.
So a nurse practitioner is a nurse, but it requires that you have your registered nurse, which is what probably the majority of people think of when they think of a nurse. That means you have 4 years of college to get your registered nurse. And then to become a nurse practitioner, you have to get at least a master's degree. So at least 2 more years of college. They've now included a doctorate, so you can then go on 2 years beyond that if you want. But so at least 6 years of schooling.
That's a lot. And I also understand that in some states you are able to prescribe medication and do diagnosis and act as, I think here in Arizona where I am, and you are where now?
Arizona.
You're in Arizona too. So I think in Arizona that you guys can have a practice and actually, which you do, you now have a private practice in psychiatry. Is that correct? Yes. Now I'm just curious. I've always wondered why would you pick psychiatry over doing like internal medicine or just general medicine? It's a new thing. I mean, we've just really started understanding the brain since the 90s with our MRIs and CT scans and all that stuff. So is that what interested you?
So yeah, nurse practitioners, actually, the first ones were made in the late 90s, early 2000s, depending on the state. That's when the first programs and the first approvals came through. So I was in school during the 90s. And yeah, and I was kind of the unofficial go-to counselor. I was the shoulder for everybody to kind of lean on and the ear to listen to. So I kind of had practice, and I kind of later on, looking back, I found that I liked it. Everybody said, "Oh, you should be a teacher." I'm like, "No, you don't want me to be a teacher." That many little kids, that's not me. I'll listen, I'll educate, I'll teach, not the little kids. And so as I went through, high school and experiencing different things, and then college, actually it was one of my first real job, adult job in college. I was a waitress, and I realized not only do I like listening to people, but I can actually talk to them. I had never talked back before. So as a waitress, yeah, income is required to talk. And so I realized I can work with people. And I thought, I don't want to be a teacher. So what do I want to do? And I talked to some people, and they're like, well, what are the things you respect? Medicine and teachers. And what can't I do? Teach. So we went the medicine route, and everyone decided, and I agreed with them completely, nursing school was going to be a better option for me. So that's, when I read the options, I'm like, definitely mental health. This is, I don't want to deal with diabetes or surgery or wound care. I respect them completely because I can't do it. But everyone has their specialty and what they prefer, and mental health was just the fit for me.
Gotcha. So as I understand you to say here, number one, nurse practitioners are new. And so is this, right. And so basically a psychiatric nurse practitioner is kind of new. So an interesting practice. Can you explain to me kind of your typical patient?
That's the thing. There is no typical patient. Everyone is unique, and that means their mental health is unique. There are plenty of, the official studies of twin studies. These are identical people genetically, but they're raised in different households. And so they have a completely different experience. And when you bring them back together as adults, they never met each other. They're two different people because of how they were raised, what they were raised around, nature versus nurture. Obviously, nature affects it, but so does nurture and environment.
Very
Then
much so. Very much so.
you can have twins or siblings that experience the same exact thing. Let's say they are in a major car accident or something happens to a family member or a friend, and they both have a similar relationship to the situation. They're still going to respond differently even though they have either the same or very similar genetics. Everyone views things differently.
Okay.
That's where I kind of think of it like we're taught in school. That's the color blue. They show you something blue. I see it one way, but the person next to me and the teacher are actually seeing it a different way. We're just taught that's blue. I ran across someone who was colorblind. They never knew. And it was because the teacher said, that's blue. And they said, okay. So they learned that was blue until they were given a colorblind test. So that really educated me on how different we can view things. And that's the same with mental health. Somebody is anxious and they're like, oh, this is the most horrible situation ever. And somebody else looks at it and goes, you dropped your pencil. It's really okay. To that person having a panic attack, it's not okay. Somebody who has bipolar and is in a manic state thinks it's perfectly fine to fly across the country, buy a new house, and marry somebody and try things that I've never tried before. Whereas everyone around them is going, oh my gosh, you're ruining your life. But in the moment, it's fine for them because that's how their brain is processing. And then you get to the more severe where you have psychosis going on and everyone used to say, oh, well, you're just crazy. You're making that up. It's not real. I really hate that one. It's not real. No, it is real to them.
For
So
them.
if they're seeing and hearing, a 6-foot rabbit, back to the movie Harvey, and it's talking to them, it is real to them. It's all about how our brain processes things and tells us. We don't understand the brain. We're starting to, much better than, oh, it's this squishy thing in our skull, but it's still really a lot in there that we don't comprehend, and how the senses, what it feeds it, and then what the brain puts out can be very different for people. So every patient, every client, every person with or without mental health is unique. There are no two people that experience things the same. There are no two people that have the same mental health, even though it's the same label.
Right.
But there is no typical, and there's that
Okay, that's
severity
good
of,
to know because that brings us to the tardive dyskinesia, which we're actually here to talk about today.
Mhm.
Um, and so that's a good foundation for people to understand that not everyone is going to be susceptible to tardive dyskinesia. And let us explain to the audience. Can you explain to the audience what it is?
So tardive dyskinesia, ugh, I love our words, is what we call movement disorder. So that means the body is having movements that the person does not control. It is a response in their brain that is not their choice. Um,
Mm.
this is considered a lifelong event if you develop it. Um, and people a lot of times will say, well, I have tardive dyskinesia. We call it TD because we don't like our words. So TD, when actually it's something else, something that is reversible, that is called I can't say it, pyramidal side effects, EPS.
Okay.
EPS is temporary. They're both caused by the same medications.
And what are those
Um,
medications?
typically, it's antipsychotics. There are
Okay.
very few non-mental health meds that do it, but the bulk, of medications are the antipsychotics because these two movement disorders are dopamine affected, and that's what antipsychotics work on. So,
And I did a little research on dopamine. I was astonished it's a chemical, correct?
yes. So every
It's a chemical in the
neurotransmitters.
brain. You have dopamine, serotonin, norepinephrine. I mean, you have some other things. These chemicals in the brain help, as I understand. I think I learned this in my NAMI classes because we're here as part of the National Alliance on Mental Illness. But as I understand, dopamine and serotonin play a key role in your moods. Well, dopamine does. Dopamine does a lot. Could you tell folks what dopamine does?
So that's another going back to we're not 100% sure. When you read the labels of your mental health medications, like the extreme science of it, pretty much all of them, they say, we don't know why this works.
It's
Yeah.
a little scary.
Yeah. It's very scary if you actually read it. But that's just because we don't understand the brain. The
Mm,
reason we know the medications work is because we've seen them work. We can tell you what
okay.
the medications do. An SSRI increases your serotonin. Um, the
An antipsychotic, what does that do to the dopamine?
it decreases it.
Okay.
Um, so again, we know some of what it does, but it's more from watching. We know the
Okay.
meds will affect the dopamine, but we don't
We're
know
not
why the
sure.
dopamine causes that. Yeah, because for some people, again, going back to everyone is different, I can give somebody
Mhm.
an SSRI, it works. Next person, I give it to them, it doesn't work. I have people that are on antipsychotics and mood stabilizers, what we call those, alone for depression.
Oh.
It doesn't make any sense necessarily when you're looking at it from a scientific perspective, but that's how their brain works.
Okay, so it's kind of making me a little anxious, and I'm wondering if my audience is. I mean, medications are complicated, and especially when you're having a medication that changes your moods and changes your thoughts, it's really scary to consider taking this medication. So why would anyone want to do it when you were so unsure?
So it's risk versus benefit.
Okay.
So if Harvey the 6-foot rabbit is being nice to you, he's saying,
Mhm.
oh, you're a good person, you got a good night's sleep, let's go for a walk, make sure you stay hydrated. Harvey's fine. Why mess with Harvey? If he's not, at first it's probably gonna be scary. Why is there a rabbit talking to me? Everybody says it's in there. But if Harvey's being nice, maybe even encouraging, that's fine. But as soon as Harvey starts saying, I'm gonna hurt you,
You're not worthy.
I'm gonna
Maybe you
hurt your
should.
family, you're worthless, you should do something bad, that's a problem. Because
Mhm.
if somebody is beating on you constantly, you have a chance of giving up and actually doing what they're saying.
Yeah.
And even if you don't give in, that's depressing. That's going to impact your mood. It's going to scare you. It's going to isolate you because you're afraid what might happen if you're around other people. So it really can wreck someone's life. Um, and that's why we suggest the medication.
Okay.
Um, it's for
In
we
other
call it
words, they
quality of
kind of
life.
can't. They kinda can't control these negative thoughts, and these negative
Mhm.
thoughts could either end up causing harm to themselves or others. Is that the concern?
Yeah.
Okay.
And
So,
and just the quality of life. I mean, if you
okay.
can't function, you're scared, you know, it's Harvey causing the anxiety and the depression. You don't have anxiety and depression, but somebody constantly berating you, being mean
Mhm.
to you, you're going to crawl up in bed, pull the covers over your head and say, I'm not doing this. Uh,
And I wanna just stop you there because this is an important point that I found over and over in my research with mental health and in these podcasts. I'd like to just remind the audience of something called adverse childhood experiences. And
uh-huh.
and can you tell me, is this kind of the new way that folks like you are quantifying the risk, based from nurture damage? That's what we're doing now, correct? Using adverse
That
childhood experiences.
that's what we're supposed to be doing.
Okay.
It is Scientists don't like change. And medicine is a science, relatively new, and mental health is even newer. So we have these wonderful things like the ACEs scale, Adverse Childhood Events Scale. Um, it's not terribly complex. It is a little time consuming, but we can have people fill them out so we have an idea, because
And what do
we
you
know.
ask people? Could you tell the audience what you ask people while they're filling this out, just so they know?
Uh, we usually let them read it because there's a lot. It's like 60 or 70. It's actually one of our longer ones.
Hmm.
But if it brings up any questions, like a lot of times I'll say, have you had any trauma, any abuse? And somebody looks at me and goes, what do you consider trauma and abuse? No, no, no. It's not what I consider. It's what you consider. Because again, it goes back to somebody may have witnessed their mom being beaten every day and had no effect. They're just like, mom made choices, it put food on the table, and they're fine. Someone else sees a fight, sees that same fight, and they freak out. So it's, how does it impact you? And we
Well, but
do
what I'm
find that it,
Mhm.
it definitely impacts mental health. The younger you are and something happens, I guess it's a snowball effect. It makes
Well, what
things.
I'm trying to also get out of you is, for parents, just a curiosity. And the reason I'm digging into this is that it's part of our mental health challenge. And I think a lot of people dismiss that. The way they say, just get tough, get over it. I've talked to different cultures. The Black culture says, sweetie pie, let's just pray over this, give you a glass of lemonade, and you rock that out. The Hispanic culture will also use a lot of prayer and religion to get over it. But in my culture, I come from a farming community and ranching community, and they were just put on your big girl britches and go out and work it off. And this is a stigma, this is an expectation. And so where I'm taking you right now is trying to help the audience, because TD is a stigma upon a stigma.
Yes.
First, you have to get over the stigma to walk in the door and say, I need help. And then second, you get this condition based on the medications you've took that you had stigma about taking in the first place. So we're dealing with piles of stigma here. And I'm just
Yes.
trying to help people understand, how do you deal with that as a professional?
As a professional, you just try and encourage, you try and educate, because if you don't know what you're putting in your body, that's not fair. Um, you try and open up the lines of communication, because not only will they hide it from their friends, family, coworkers, they may not even tell me.
Right.
So I need to present a front that says, you can trust me. I'm not going to, you've all seen this, nurses and doctors standing at the nursing station at a hospital going, oh, can you imagine the guy in 1B doing blah, blah, blah? Ugh. Nobody wants to be talked about. So, they need to trust me. I need to let them know they can trust me. I need to let them know I'm not going to judge them for seeing Harvey and for having a movement they can't control. Neither of these things are their choice. They didn't
Right. So
choose to do this.
since it's difficult for you to get them even to come into your office and admit that they've got an issue, and now they've got this movement issue, how can you see these movement issues whether they tell you or not, or is it hard to figure this out?
Some people, you can see them. It usually, the majority of cases are in the face, jaw, like they're chewing, or their tongue is moving. Um, Sometimes you'll get like blinking and cheek movement, things like that. The big thing is the hands, because they'll be moving. They can't control them. Um,
Not like a Parkinson's shake, but literally moving.
yeah, I'm not a good example of the hands. Not
Okay.
a Parkinson's. We actually say, is it a Parkinsonian's movement? Because that's different.
Yeah,
And
okay. Okay.
if it's a Parkinson's type movement, there's a good potential they're going to a neurologist,
Yes.
because that's not us.
Okay.
That's still a dopamine issue, um, but that's not us. So we also need to be able to differentiate between the movements. Um, it can happen anywhere in the body, however. It can be neck twitches. That's got to cause a lot of muscle spasms, I would think. Shoulder movements, whole arms, hips, so they can gyrate. It can be leg movements. It can be ankle and toe movements. So some of these are a little bit more hideable. I mean, how many doctors' offices, if you're not going to a podiatrist, ask you to take your shoes and socks off? You know, if I'm walking into a mental health provider, I'm not going to be like, sure, I'll take those. Why do you want to see my toes? So we have a test that we can run. It's very simple. It's like 5 or 6 things. We ask the person to do that is supposed to help us um, elicit or cause the movements, because we're trying to get them to, even though I say they're not controlled, they can learn to control it, kind of tamp it down. And so, depending on the movement, so they learn coping skills um, to hide them. And so the test is actually to get them to drop those defenses, because their brain actually cannot focus on 2 things at once when they're trying to control the movements. Nobody knows that. Only the providers are supposed to know that. But if you're actually doing the test, your brain just can't.
Gotcha.
And so it's supposed to check the whole body. So
Okay.
theoretically, we are supposed to ask them to take their shoes. Um,
It is what it
but
is. I mean, you have
yeah,
a. So I've got to ask you, this seems like it might be hopeless. You're saying that TD, once you get it, you can't get rid of it. But can you give us some hope about this condition? Because let's see, let's go a little bit of the history of the condition. You told me
it's very
that,
scary.
yeah, yeah. So
No,
this condition didn't really show up until antipsychotics of the 80s and 90s. And okay.
50s and 60s.
Oh, 50. Whoops. Way back.
Yeah, we didn't acknowledge the condition was there. We did not acknowledge the condition. Just like, these disorders have been around for hundreds, probably thousands of years. We didn't acknowledge those either. Why do that? That's silly. Um, but antipsychotics were introduced in the 50s and 60s, depending on the country. And our younger people may not know this, but our older people recognize the phrase, the Thorazine shuffle. That was not TD. That was actually a side effect of the medication, but that put them at high risk, being on the Thorazine, to develop TD. So if they were lucky enough to get off the Thorazine and not shuffle like that, they may develop a shuffling type movement anyway, because they developed TD. The older medications are rougher. They are much more likely to put you at risk. This is all a risk.
Ah,
Okay.
gotcha.
It's not a guarantee, so
Correct. Because you were saying early on, everyone's different. Everyone has different chemicals. And so some people will be able to tolerate these antipsychotics and not get TD, and other people will be more susceptible to it. And that's the
yes,
struggle with mental health as a whole, and the
yes.
scary thing, right?
And it comes back to that risk versus benefit. So all of our older ones, that's where the 80s, it was like 89, 90 when Clozaril and Risperdal came out, late 80s, early 90s. After they started, 10, 20 years later, they realized that group of antipsychotics put the risk of developing tardive dyskinesia even lower. So what that means is, if you're worried about tardive dyskinesia, the newer ones are safer in that it's a lower risk. I know that's kind of a mouthful. Um, but it's all based on percentages, unfortunately. I can give 10 people the same medication, and I have to see what the side effects are. What are the long-term effects? And that's what the scientists do. That's the scientist's job. That's what causes that giant booklet at the pharmacy of, oh, this could cause anything from, constipation to death. You're like, why am I taking this? it's
Right.
it's all a matter of percentages, and that's why it's so important to communicate. I'm a psychiatric nurse practitioner. I'm not a psychic. I am not a mind reader.
Thank you.
Um,
Yeah.
so unless you tell me or I can see it with my own eyes, I have no idea. And that's why communication is so important. Um,
Do
so,
you have regular follow-up appointments after you start the medications? And like, is there a time frame in which you might see TD show up?
so first you're going to have the EPS. Um, that is treatable a couple of ways. Medication, yet another medication, um, to block the side effect of what we already caused. But some people can't go off their medication. Bad things can happen. And so we can treat it. If maybe there's a different medication we can use that won't have that side effect, comes with its own risks, but maybe there's something we can give somebody that won't have the EPS, those movements that are temporary, because the those movements only happen for as long as you're taking the medication.
Ah,
When either the side effect medication we give you works, or we take you off the medication and the movements stop, that means it's EPS. That means at that point it is temporary. You don't just jump to TD. You start with EPS.
this is good for people to know. Please listen. Just if you're
Yes.
getting movements, don't be afraid and trust
Don't be
your
afraid.
practitioner and come to them and say, this weird thing is happening.
Yes.
Find someone like Melinda, please.
And EPS can even be a muscle tension. Usually people describe it in here,
Hmm.
or a tightness in the jaw. They're like, I can't really move my mouth like I used to.
Okay.
So it's not just a movement, it's kind of a lack of movement, muscle pain, tension is a lot of how people describe it. And I'm like, well, you don't have anxiety, so why are your shoulders getting tense? So, and that's the hard thing. Mental health, a lot of things share things. I can't sleep. Oh, good. What's causing that?
Right.
It could be depression. It could be anxiety. It could be Harvey's keeping you awake. Same thing with side effects. We need to figure out what's causing it.
Mhm.
And that's where, again, communication. So then I ask, okay, did something happen? Did you have this new experience? And we find out it's anxiety. No.
Okay.
Okay. So this is the first time I'm seeing you. What meds are you on? Oh, well, my primary care doctor started me on blah, blah, blah. It's an antipsychotic. Because
Wait,
primary care won't be nice and start their mental health meds.
so primary care can subscribe
Mhm. Before,
antipsychotics.
yeah, before mental health and psychiatry, that's who was doing it. There've never been enough specialists of any kind, and mental health is a specialist. So we have a lot of primary care doctors doing mental health meds. Some really that shouldn't be. Some of them do some scary things, but that's because they're
They're not
generalists.
trained.
They're
They're
not
just not
trained for
trained.
that. Yeah,
No.
somebody comes in, says, "Well, this works for me," and the doctor says,
And they're not trained necessarily to know about TD and the
"No,
consequences of TD. And they might
not at
misdiagnose
all.
as
No."
Parkinson's or just say, go get a massage because your shoulders are tight.
Yep. Yep.
Wow.
So then
Hmm.
when they go off the medication, or the side effect medication, the one to block the EPS, doesn't work, the movements are still there, that's when we start to consider TD.
Okay.
Um, because, well, everything we're doing, it's not affecting it. Um, and that's where we look at the TD.
Okay.
We were always
What
told
happens then?
one,
If you have TD, is there something you can do about that?
yes. Yeah, it's very, very good. Um, about, oh gosh, it's been at least 7 years ago. Um, New medications came out, and it actually helps TD. So that can be anything from reducing the movements, so they're still there, but they're not nearly as severe, because there can be extreme cases, to there are no movements. Like, the person doesn't even recognize any more movements happening. Um, so unfortunately, prior to this, these two medications came out right about the same time. That's how science works.
Yeah.
um, before that, we didn't really have anything. Because unfortunately, the EPS medications don't really help TD. Now, I have seen a few people that are unlucky enough to have both EPS and TD. So
What?
sometimes, yeah,
How does
it's
that
not
work?
pretty. Basically, they get put on a TD med and an EPS med. um, their brain decided part of these are permanent and part of these are not. So
Wow.
yeah, so now they're taking at least 3 medications. 1, their antipsychotic; 2, their EPS med; and 3, their TD med. But for the one person in particular I'm thinking of, they walked into my office in tears saying, "I've never not had movements. And I can say, since you started those meds, I have 0." So since they had
Wow.
started, they had never not had a movement, and they were so happy. They were just crying. I was so happy for
So
them.
that
It was
brings me to
amazing.
a question for our audience. Can you explain how these movement disorders affects your patients' lives? Do you have a couple of stories about how, because we're actually, I was just listening on the radio as I was coming in for this interview, and there's a with Medicaid, a lot of patients that are having things like movement disorders or mental health crises, they can't work. They literally can't, and they're now having a requirement that with Medicaid you have to work. So, can you describe for me how a movement disorder would affect your life that much that you can't even work?
Yeah. So it can be something as simple as they're having a hand tremor. They notice their signature changes. Most people don't sign anything anymore, but they notice their writing is changing. And they're like, why does my scrawl look like, a grandmother? That doesn't seem right. I'm 25. um, it can be um, that their mouth is moving so much, they're having a hard time eating. Um, if it's their tongue, it can actually push the food around to the extreme that it could push the food out, or just everybody's like, why are you eating like a 2-year-old? So they don't want to eat around people. Lunch break. um, they could be in a very masculine type atmosphere. They're working in a factory. Lots of men, burly men, and they're having this twitch. Come on. You get a group of people around, they act like high schoolers, they bully each other. um, and, it could be to the point, if their hips are gyrating, they can't stand still. Um, it, it can be, there are videos out there of extreme cases, that the pharma companies, the drug companies that made the TD meds share with people. These patients agreed, and they can show you the before and the after. And the after is amazing. Don't get me wrong. It is wonderful, but you would not believe how extreme these movements can get. That literally like every piece of their body is moving, and it's not just a, little, it's extreme. They're wiggling all over the place and they can't do anything. That's why it's so important, because the longer you go with it, the worse chance it has to get,
But that's
because
so
you're
much with
probably still on your
medication.
medication. So
And so what I want the audience to realize is there's a reason that people with a mental health condition have a higher unemployment rate than people with even a physical disability.
so you've
It
got
scares
Harvey
people.
talking to you, then you have the movements, embarrassment, inability to do certain tasks when your boss is saying, well, you have to stand at that cash register. What do you mean? They literally can feel antsy inside. I always tell people, do you feel restless, antsy when you get anxious? Yes. This is going to be different. If you have both, you're going to be able to tell them apart if you think about it. And that's why it's so important to really open those lines of communication, that tell me how that feels. Is this the same as the 20 years of anxiety you've had? Or does it actually feel different? Is it happening at a different time? Is there a different trigger, a different cause? Has anything else changed? And here in Arizona, people on psych meds can get dehydrated. And if you live in hot climates, you know that that's really bad. You know, it's different from when you're up in the wild blue yonder up north. You get dehydrated here, headaches, you know, you might have to go actually get, we have plenty of people in the summer who have to go to the ER and get an IV infusion. We have people pass away just from the heat. I've had people pass out and get burns on the blacktop here in Arizona. Um, that's even worse because then you're even more dehydrated from the burn. So you can actually get a tremor with certain medications when you get dehydrated. So that's why it's so important to talk to your provider. Because again, I'm not a mind reader. I promise my coworkers are not mind readers. We only get at most, you know, in a good practice, we get half an hour to talk to people. Once a month, half an hour. That takes a long time to get to know you. Some practices, it's 10 or 15 minutes every 3 months.
Yep.
I have
And
to
so
know or I
that's
can't help.
hard. So I have a question for you. If someone comes to you, would you suggest that they do talk therapy along with their antipsychotic medication? And part of that talk therapy would be how to learn to live with their condition, or do you help them with that? I'm not sure where the line is because I know my daughter has a psychiatrist. Basically, he's there to make sure all the chemicals aren't crossing over, not the talk therapy thing.
It depends on the provider. Um, it's a lame excuse, but everybody in medicine, that's what they say. Um, you know, is am I going to listen? Yes. I have a coworker who specifically says, "I'm here to do meds. I don't want to hear that stress, that stuff. You know, go get a therapist." I want you to get a therapist, but just like any provider, it's hard to find a good therapist. It's not just, oh, they're good. You're putting your life out to them. You are making yourself so vulnerable. A lot of times it's more vulnerable than your significant other because there might be things you're not comfortable talking about with your significant other, or you're not going to have these in-depth conversations every week about the same thing with your significant other. So there has to be an interpersonal, a good relationship. Um, the majority of people benefit from therapy. Meds are the second step. Some people have to be on their meds. Some people don't have to be in therapy because they've already figured it out. And therapy isn't the only option, but that's the, oh, we were trained, we're professional option. You can get therapy from your friend, from your pastor. You know, it doesn't have to be a professional. It has to be someone who's good with you and is going to give you good advice. And the other part about therapy that a lot of people ignore is you're supposed to be challenged. You're supposed to be learning. You know, we always say, oh, go to therapy, get coping skills. If I'm told to go to therapy and I'm just like, I'm fine, you're not going to put the work in. Same thing, the therapist may just want to be your vent buddy. You know, what are you getting from that? People are like, well, I want to give him another chance. You've been seeing him for 6 months. Please go get a different therapist. It's okay. We're professionals. Guess what? We're getting paid to be here. It is your time and your money. If you're not getting something out of it, you are allowed. You have that right. You don't have to keep coming to us. You can find some. Now, please probably find somebody else, especially meds. Find somebody else first. Um, but if you're not getting anything out of it, you feel, heaven forbid, worse, or at least not better, go somewhere else. And a good therapist is one that you don't want to leave. I have so many
Well,
people
I
that say, I
actually,
wish they hadn't moved.
yeah, I I actually went to a therapist who held me incredibly accountable for my codependency.
Uh-huh.
Um, And that's what I needed. I needed to have my actions. I needed to stop being in victim mode. And that was hard. But we also had a
Yes.
treatment plan. And I, after a year and a half, got as much as I needed out of her. And then I moved on to another therapist who actually helped me with somatic body healing. There's
Hmm.
multiple layers of healing as well.
Yeah.
And that is one of the hardest things for patients, isn't it, to advocate for themselves?
Yes. Um, good therapy is not easy. And it's so much easier to just fall into the groove of, oh, I'm going to go talk about my past week. And I ask people all the time, are you getting anything out of it? No. Are you going to find someone else? Uh, Change is not easy. And that includes even just a new provider. If you're super anxious, trying to tell your story yet again to a new person who you don't know how they're going to react is extremely scary. Doesn't matter who you are. Interacting with a stranger is not easy. And we're asking you to open up and tell you your life story, including the very worst things that have happened to you. It's
That's
not a
a hard
pleasant
ask.
experience. Yeah.
Yeah, no, it's not, but I know that after you go through the discomfort, and I have, I've gone through a lot of discomfort reimagining and rephrasing how I think about myself and self-talk, as well as how I look at my family and how that all worked. And I found peace because I've been able to reimagine what's going on. So coming back to the TD, um, do you have any final thoughts for people about this? I feel my heart goes out for them. Like I said, the stigma upon stigma with this thing. And I wish I could take that pain of stigma and remove it from them, because all people really want is for you to feel good, right?
Hmm. Yeah. You shouldn't be in this business if you don't want to help. Um, the key is TD is rare, but it is very impactful. So if you have any concerns, any side effect, but let alone the movements, talk to your provider. Ask them, what can we do about this? Because you do have options. Not a lot, but at least there are options,
It's
and
not
they're
hopeless.
better. Yeah, it's not hopeless. Even if you have TD, there are options. And I've seen what I would consider miracles for people that it's life changing. It really is. So please speak up because it's the only way that we can help. And it's what matters is, do you feel better? That's the real question. Because if you feel better, that's what matters.
And just to wrap up, you do have a private practice. Are you taking new patients, or can you refer people in Arizona to, what should they do, at least in Arizona? I know you come from a different state and you worked with a larger mental health organization. We have a few of them in Arizona. Here in Payson, we have something called Southwest Behavioral, and we have something called Community Bridges. I think they're in other communities as well.
Mhm,
You're in the Phoenix area though, correct?
mhm. Yeah.
Right.
So the sad thing is the big cities, the big epicenters have a lot more resources and you have more options. Um, However, because depending on your insurance, there are the big centers, there are small practices, there's individual practices. But one of the strange good things that came out of COVID is mental health finally moved into telehealth, into this virtual platform. And so that really helps the smaller communities because maybe you live in a town of 500. We have those here in Arizona. And there's literally no psych provider for 2 hours. And primary care is like, you're on an antipsychotic. I'm not comfortable with this. So now a lot of providers, a lot of practices, a lot of those big agencies, they do offer those telehealth services. We have people, again, maybe Harvey is isolating you. I can't leave the house. Some people really can't. That's not just I don't want to leave the house. I really, really don't. I can't. And so telehealth has helped a lot of people between those really isolated communities to the people that really can't leave the house, but they need meds. And the same thing with therapy is also now, again, one of the very, very few things from COVID that was good. Therapists are offering telehealth services. There are drawbacks to it. It's not for everybody, but at least it's an option now. So,
And so what would you suggest? Do you suggest somebody calls their insurance company and say, "Hey, I need help with my mental health," and they can help you go find someone? Or, I mean,
so
how would you
that
suggest as a professional?
you can call your insurance, but honestly, those lists usually are not up to date. So you end up calling like 5 to 10 people and they're like, we don't take your insurance. Oops. That's very frustrating. You just feel like, why am I trying? Um, Usually, you know, you can Google mental health. You'll find out put your city. You'll find lots pop up. Usually it's the bigger agencies and bigger practices. Um, there are search engines like Psychology Today. There are plenty of big places. What is it? Better, Rule of Health, um, Cerebral. There's lots of places that are either insurance based, cash pay, which is self pay, or usually a hybrid of both. And so some people don't want to go through their insurance. I have people that it's cheaper to cash pay than go through their insurance. So there's lots of options out there. The other thing that a lot of us get a referral from, talk to your friends and family. If you think, well, cousin Bobby kind of has what I deal with, I think, maybe have a conversation. We get a lot of referrals from friends and family. It's going to be somebody you're comfortable with, but it's not like you have to open up their life story to them. But, hey, does anybody know somebody who might be able to give me some therapy or give me some meds? Usually those are the better referrals for the person because
Okay.
that person knows you and they may know if it's going to be a good fit for you. Um,
Good advice. Thank
everybody,
you.
yeah, everybody has somebody with mental health in their life. They may not know it, but you do.
Well, I mean,
So,
I actually lost my first husband. I was divorced from him, but he's the father of my children. And death, just having that death in the family changed my relationships with my kids. I didn't respect that until it happened. So these life events, these traumatic life events like a death in the family, a long-term
yeah.
illness, a loss of a job, these can all spur a depressive episode.
Uh-huh.
What we say at NAMI is that if it's like over 2 weeks and it's getting in the way of you being able to function, and you would agree with this analysis,
Yes.
go find some help.
Yes. And that's just it. Everyone has mental health. It's a matter of, is it affecting you? And it doesn't have to be lifelong. For a lot of people it is, but there's also a good group of people that I got anxious when I lost my job. I wasn't working for 6 months. They start working and they feel better.
Right.
My
So,
goal is to make you feel better and not need me if possible. I would love to change fields if nobody ever needed me again. So
well,
unfortunately,
we're
that's
going
not
through
going to happen.
really we're going through a really difficult time just with the culture right now. And I know a lot of people I talk to, just the anxiety is there. It's just this background. And then the pandemic also was a huge trigger for everyone, that isolation. And so I think that right now, I'm really grateful that folks like you are coming out and that NAMI is doing things. And I think there's a grant that you have with TD that we're working with. So there's a lot more information and a lot more ending the silence, like my shirt says. I'm part of that program. Um, we don't necessarily in ending the silence get this detail oriented, but on this podcast, it's really nice to be able to really get into these conversations a little deeper and help people just let go of the shame around mental health and medication. So
And
I
that's the only way that's going to end the stigma. Yeah.
thank you. Thank you exactly for saying all of that. You are wonderful. And we might be coming back. We're going to be coming back with another one talking about families and what you've seen with families and how they can help and hurt mental health. So Melinda, thank you for your time today. I really appreciate it. I think it's going to help a lot of people.
Thank you.
Melinda offered us a compelling look at the impact of tardive dyskinesia, heartbreaking medical mystery. Sufferers have a strange mix of movements from tics to involuntary muscle spasms and tongue thrusts. Doctors say these movements stem from a reaction to certain antipsychotic medications, mostly used for things like schizophrenia, bipolar, and psychosis. The essential neurotransmitter dopamine lies at the heart of the mystery. No one knows for sure what triggers the disorder, and no one knows why it can become permanent, even when you stop taking the medication. But Melinda can attest to the huge impact it has on the life of her patients. Those with TD not only struggle with mental illness, but also the burden of the reaction of other people to their body movements. Melinda explained what researcher Dennis Story found applies mostly to the older generations of antipsychotics. Story's research discovered that tardive dyskinesia arises in somewhere between 15 and 40% of people on long-term drugs that block the uptake of dopamine in the brain. But Melinda said the newest antipsychotics have a much lower potential of causing TD. In addition, there are some new medications that reverse TD symptoms. Research shows that TD's bizarre collection of symptoms tell us something terrible and wonderful about how the brain works, in particular, the role of dopamine. Dopamine is a chemical messenger called a neurotransmitter. It's produced deep inside the brain. Dopamine plays an essential role in brain function, which includes feelings of pleasure, satisfaction, memory, mood, sleep, learning, and movement. Dopamine imbalances play a major role in drug addiction. Too much or too little dopamine can cause depression, schizophrenia, and psychosis. Too much dopamine can cause aggression and uncontrollable impulses. Low dopamine levels leave you less motivated and can also cause the muscle disorders of Parkinson's disease. Dopamine imbalances can cause cramps, spasms, and stiffness. It can also cause a low sex drive, hallucinations, fatigue, and loss of hope. Basically, dopamine helps the brain and nerve cells to talk to each other. So you see, it's very complicated. Diet can help. Research says eating things like nuts, seeds, and dairy products can help because they contain tyrosine, the protein the brain needs to make dopamine. Exercise and sleep can also increase dopamine levels. But for many severe disorders, like bipolar and schizophrenia, you need medication. Medications aren't the only cause of tardive dyskinesia, but they remain the most common. Now, we're making progress on understanding the complicated impact of dopamine on mental health, but we still have many more questions than answers. One survey of TD patients found that the movement disorder has big impacts on sufferers. A third quit their medication despite the risks. About 29% were chronically absent from work, and 69% said they were much less productive when they did go to work. Fortunately, the survey also found that new dopamine-blocking drugs are much less likely to cause the disorder. Now, please remember, we're not doctors, so please don't rely on this podcast to diagnose your problems or to select a treatment. Find a professional like Melinda, preferably one who has experience with diagnosing and treating TD, especially before you discontinue one of those dopamine-blocking antipsychotic drugs. And make sure the professional you talk to knows all about those third-generation drugs. So when I read the research, a couple of things seem clear. Medications that affect dopamine can restore the lives of many people suffering from severe mental illness, but they come at a risk. Despite that, don't give up. Get informed. Find a doctor who will listen, like Melinda, and who is up to date on the latest medications that regulate dopamine. Most of all, don't let shame and fear isolate you. Come join us in ending the silence around tardive dyskinesia.
It's okay to just be me. We're all made to be unique. It's okay to have my needs. It's okay to be me. What's easy for others are struggles for me. I do things differently. doesn't make me broken, it just makes me me. People out there help me through, ones who care about me and you. Through my struggles I find my strength, feels so good to be me. What's easy for others are struggles for me. I do things differently, doesn't make me broken, it just makes me me. People helping me to get through have their own struggles too. Even though they have their strength, they are human like me. Through these struggles we build our strength. We all want to feel healthy. Even though we make mistakes, struggles build our strength.